Welcome back to part 2 of the TBI lecture. In part 2, we will discuss the management of traumatic brain injury as well as the complications of TBI. So what exactly is primary injury? So when we talk about traumatic brain injury, we divide it into primary injury and secondary injury. Primary injury is the initial external insult to the brain. The bat hitting the head, the grenade going off, somebody putting a knife through the head, etc. Secondary injury is the exacerbation of the biochemical cascade caused by the primary injury. And when a patient comes in with traumatic brain injury to the ICU, there's absolutely nothing that we can do for the primary injury, but we can help prevent secondary injury. So what exactly can we do? Number one, we know that both hypotension, which we define as a systolic blood pressure less than 90, as well as hypoxia, which is defined as an arterial oxygen tension less than 60, are both independent predictors of worse outcomes. So if somebody has a GCS that we described before in the slide on Glasgow Coma Scale, less than 8, we would intubate. And part of the reason is we want to make sure that not only can they protect their airway, but that we have full control of the oxygenation of the patient to make sure they have no hypoxic episodes. Other things that we do is prevent hyperthermia. So what we know is that hyperthermia increases the cerebral metabolic rate and therefore requires more nutrients. And in the setting of acute traumatic brain injury, there may be a mismatch of these things. So we try to shoot for euthermia. And in fact, if we have a little bit of room and somebody's not coagulopathic or hypotensive or hypokalemic, we actually attempt to obtain a little bit of perhaps hypothermia, maybe a degree or two. Because we know that for every degree below normal temperature, a patient's cerebral metabolic rate decreases by 8%. We also know that hyperglycemia is not good in the setting of acute brain injury. We have an increase in intracellular acidosis of the brain cells. Hypovolemia is self-explanatory. If you're hypovolemic, you are at increased risk of developing ischemia to the brain because you have decreased blood flow. The other thing is hypocapnia. So in somebody who's actively herniating, we try many things first, which we'll discuss in a second. And the last resort is hypocapnia. And how does that work? So CO2 is a potent vasodilator of the cerebral vasculature. In fact, it is a vasodilator of all your body's vasculature except the pulmonary vasculature, which actually vasoconstricts with elevated CO2s. And you can imagine if we have dilated cerebral vasculature, you have more cerebral blood flow and therefore more cerebral blood volume, which obviously by the Monroe-Kellie Hypothesis, which we'll describe in a bit, increases your intracranial pressures. We acutely lower the CO2 as a last resort, but it comes at the expense of cerebral ischemia. And then the last thing we try to prevent is intracranial hypertension. Okay. So now I'm going to turn to cerebral perfusion pressure, which is a topic that's often tested in the USMLE. Cerebral perfusion pressure is your mean arterial pressure minus your intracranial pressure. So that makes sense, right? You have a mean arterial pressure, which is at a heart rate of 60, calculated by the formula of 1/3 systolic plus 2/3 diastolic. So that's your mean pressure that's going into the brain. And then you have this intracranial pressure, which is the pressure in your brain. Now, CPP in the form of this kind of formula only is correct if your CVP or your central venous pressure is below your ICP. If your CVP is higher than your ICP, then your CPP would actually be your mean arterial pressure minus your central venous pressure. So what is that normal intracranial pressure? So the normal intracranial pressure is 5 to 15 millimeters of mercury or torr when you are supine. But one thing to remember is the conversion of torr to centimeters of water. So 7 millimeters of mercury or torr is about 10 centimeters of water. And that's important because when you come to the bedside and somebody has an external ventricular drain, which we'll describe later, which is a drain of the CSF and a way to measure intracranial pressures, the actual EVD is calibrated in centimeters of water, while the pressures in the brain are actually being put out onto the computer or being reported in millimeters of mercury. So the conversion again is 7 millimeters of mercury is equal to 10 centimeters of water. So what is our goal? So our goal cerebral perfusion pressure is 50 to 70. What we know is that if we go above, if we try to shoot for a cerebral perfusion pressure greater than 70, there are increased risk of complications, and that may be perhaps because a patient requires inotropes or vasoactives that may increase the risk of having some cardiac event, pulmonary edema. Your goal intracranial pressure is also less than 20 torr. If in general we say somebody's intracranial pressure is greater than 20 for more than 5 minutes, then you should be acting on it. Now I wanted to go ahead and see, so mean arterial pressure is equal to cardiac output times systemic vascular resistance. Now, and I apologize there for the camera. Let me just move this a little bit upwards. So cardiac output is equal to stroke volume, which is SV in this picture, times your heart rate. Now stroke volume can then be broken up into your preload, what comes into the heart, your afterload, how much resistance there is for the ventricle to push out, and then obviously your contractility. If you increase your preload, if you decrease your afterload, and you increase the contractility, you're obviously going to have increased stroke volume. Now, when we also talk about the preload, remember the preload is not just the volume that goes into the heart, into the LV from your volume status, but it's also very important to remember that what fills the LV is the RV. So you can actually have a good amount of volume in your body, but if your right ventricle is not working, then your LV will be hypovolemic. So always think about that when somebody looks like their LV is preload dependent and you've given them volume and they're not responding. Think about the fact that it may be a problem with the right ventricle. Okay? All right. Move my picture back here. So mean arterial pressure I have just described, and your mean arterial pressure is equal to your cardiac output times your systemic vascular resistance. Cardiac output is divided into all these factors that I just mentioned in the previous slide. When somebody is hypotensive, the way to approach hypotension is to simply divide it into one of 4 causes, and I think this will be very helpful in the USMLE. It's either a cardiogenic problem, for example, is it a pump problem, is it a rhythm problem, is it an ischemia problem, or is there a vascular problem? Sorry, not a vascular problem, a valvular problem. Again, pump, rhythm, ischemia, and valves. For example, if somebody has acute AI, you may be very hypotensive and in cardiogenic shock, and that is due because all the flow is coming back into the LV because of the AI, which is aortic insufficiency. The other thing to consider is an obstructive problem. For example, is there tamponade, cardiac tamponade, a very large pulmonary embolism, or is there a tension pneumothorax? These are all causes of obstructive shock. The third cause is hypovolemia. For example, has somebody had significant diuresis, or has terrible diarrhea, or they are hemorrhaging from whatever it may be, which is not uncommon in trauma. Number 4 is a distributive problem. So what does that mean? Are they in neurogenic shock? Are they in anaphylactic shock? Are they in adrenal insufficiency? Are they in acute liver failure with systemic vasodilatation? Do they have severe hypothyroidism? So these are all causes of distributive shock. Now, I want to differentiate neurogenic shock versus spinal shock. So neurogenic shock is the hypotensive effect of having a spinal cord injury. Specifically, when we talk about a neurogenic shock, we're talking about the loss of our sympathetic system function to the tone of the vasculature in the bilateral lower extremities. Remember, the sympathetic nervous system runs from T1 to L2 on the lateral part of the spinal cord. On the other hand, spinal shock is the actual lack of motor function or the lack of sensation. So it's actually the neural findings of the injury to the spinal cord when we describe spinal shock, again, as opposed to neurogenic shock, which are the cardiovascular findings. Now I'm going to talk a little bit about ICP monitors or intracranial pressure monitors. There's basically two major types, and those are intraventricular catheters, also known as external ventricular drains, and intraparenchymal monitors, also known as bolts. So what exactly is an EVD? So an EVD is a device, it's a catheter that goes into your lateral ventricle, which we described in a previous slide, that is sitting right in the CSF in the ventricle. These ventricles, remember, are the ones that have the ability to make CSF. And the things that make that is called the choroid plexus. This catheter, by being there, not only measures the actual pressure in the brain globally, since pressure in the brain will try to direct itself centrally, and therefore the catheter is located in a perfect position to measure the overall pressure in the brain, but it also has the ability to drain CSF. So by draining CSF, it creates more space, and therefore if you have swelling, that swelling can go into that space and therefore prevent herniation. The EVD can be recalibrated at any time at the bedside, but the EVD has an increased risk of infection by being in the CSF space. It also has a risk of bleeding risk. On the other hand, bolts or intraparenchymal monitors, as the name of it, it's a device that goes straight into the brain, and the tip of it sits in the actual brain matter. Because of that, some people argue that the bolt measures the pressure only locally and does not provide a good monitoring of the pressures in the overall brain. It has less of a risk of infection, but once placed, it cannot be recalibrated. And unfortunately, once it's placed, the zero, when you first place it, you sort of balance it to a score of 0 because there should be no pressure when it's just out in the atmosphere. Once you put it into the brain, if there's intracranial pressure, the pressure should go up, obviously. But unfortunately, these monitors have the tendency to drift to a higher pressures on its own. So it may actually be reading falsely high pressures in the brain. And again, it cannot be recalibrated. The other thing, it cannot drain CSF. It's only meant to be a diagnostic tool. And like the EVD, it has a risk of bleeding, causing intracranial bleeds. Now I want to talk a little bit about the Monroe-Kellie Hypothesis, which is basically the idea that the cranium or the skull is a stiff box with a fixed volume, and that's due to the fact that the contents within the skull, the blood, remember both the arterial and the venous, the CSF, and the brain tissue are all in equilibrium with each other. If one of these contents increases, then one of the other contents must decrease in volume to maintain equilibrium. Otherwise, you get herniation. Now, I want to go ahead and see if we can discuss a little bit about the Monroe-Kellie hypothesis. So if we take a look at this picture, what this shows is volume on the x-axis right here and pressure on the y-axis. And as you can see, as the volume in the brain here increases because, for example, increased cerebral edema, the pressure begins to rise. Okay? The first thing that happens is the brain decreases its CSF. So it does this by pushing its CSF towards the CSF in the spinal canal. Because remember, there is CSF in the spinal canal, which is called the subarachnoid space as well. Okay, so as that happens, it creates some space, but then it runs out itself, and it begins, and there tends to be a decrease in actual blood flow to the brain that allows for more volume for this swelling in the brain. So now you've decreased your CSF, you've decreased your blood volume, and therefore you've maintained the pressure constant at the 5 to 15 torr normal pressure that we described. But finally, at some point, equilibrium gets lost and the pressure just skyrockets. And that's when you are at increased risk of herniation. And that is what we basically call an emergency, and you have to do something about it. Otherwise, you will herniate based on one of the patterns that we've described previously. Okay, that is the Monroe-Kellie hypothesis. Now I'm going to step back and talk a little bit about intracranial hypertension treatment. So when you think about intracranial hypertension treatment, there are 4 ways to approach it. You can either fix how much the oxygen the brain uses to protect it, right? You can work with the cellular edema, try to fix the edema in the brain. You can either drain CSF or help drainage of the blood in the brain to create some space, or you can decrease the cerebral blood flow. So let's start with number 1. By increasing sedation, you decrease the cerebral metabolic rate, and therefore you essentially protect the brain because it needs less energy. You can cause euthermia or slight hypothermia, as we described previously, as for every degree below normal temperature, your brain's metabolism decreases by 8%. Or you can improve a patient's analgesia. More analgesia, they're more comfortable, less agitation, again decreasing your metabolism. You can decrease the cellular edema. You can give hypertonic saline. So how does hypertonic saline work? So normal saline, bread and butter IV fluids, is what we describe as 0.9% normal saline. That has a sodium content of 154 milliequivalents per liter. When we talk about hypertonic saline, we were talking about 3% saline or 23% saline. So you can imagine it's over 3 times as concentrated as normal saline. So it'd be 154 times 3 to calculate the amount of sodium and chloride in that bag of fluids. By doing that, what it does is it creates a diuresis. You get this salt load essentially throughout your body, which draws free water from the brain into the vasculature, and then you pee it out. So you're essentially sucking out free water from the brain's cells, and then peeing it out. Now there are risks associated with hypertonic saline, which include hyperchloremic metabolic acidosis, renal failure with a high sodium content as well. Now, in general, 2 cc's, 2 cc's per kilo of 3% hypertonic saline will increase your sodium by 2 milliequivalents per liter in your body. Now that's important because you can imagine, put it in a different clinical scenario. Suppose you have somebody who comes in with severe hyponatremia, and their hyponatremia is below 120, which is the number we usually begin to get concerned for seizures, and they have a seizure. So you give them benzodiazepines and they're not getting better. So you push in 2 cc's per kilo of 3% and their seizures stop because probably their sodium went up by 2 points. Now remember, both hypertonic saline 3% or 23% given as a bolus can cause significant hypotension. And the reason for that is because you're giving a significant salt load straight into the heart, and the heart has to work extra hard to push that salt load to the rest of the body. So it sort of has some trouble, and your blood pressure may drop temporarily. So you always have to be ready to potentially provide inotropy or vasoactives. Mannitol is an osmotic diuretic, and mannitol is a sugar, And what it does is similar to hypertonic saline. It draws the sugar draws fluid, which then gets peed out through the urine. If you are in renal failure, you should not be using mannitol because you cannot get rid of this sugar. Mannitol can cause renal just like hypertonic saline. Mannitol can also cause rebound increases in intracranial pressure. So these things have to be weaned off carefully if you've been on them for a while. Usually the dose for mannitol is anywhere between 0.5 gram to 1 gram per kilo, again, given as a bolus. Now, comparing mannitol versus hypertonic saline, the studies show that there really is no difference, but mannitol is much more likely to give you, make you hypovolemic compared to 3%. And the reason is because mannitol, the sugar draws the water and just makes you pee. At least with the hypertonic saline, you are providing a salt load, which to some extent will be balanced. The diuretic effect will be balanced by the fact that any water, free water that you give, will also want to stay in your body's system because you are giving salt. For example, when you have a bunch of potato chips, you take a lot of salt, therefore you want to drink water and you increase your body's total body volume. And the other thing that you can do to decrease the cellular edema is you just essentially perform a craniectomy, which is literally when you make a big hole on your skull, take off that skull and allow the brain to herniate outwards as opposed to downwards, and therefore decompress the brain swelling. The other thing you can do is drainage. So what do I mean by drainage? So simply bringing the head of the bed up to 30 or 45 degrees will allow increased internal jugular vein drainage of the sinuses, and therefore less vasculature, less blood in the brain. Cervical spine collar, if it's too tight, you press on the jugulars. If you ever had a chance to do a central line, if you take your ultrasound and you press on the internal jugular, it's very, very easy to compress it. You can imagine you have a collar that presses both of them, you're obviously going to get some backflow. And then you can provide an external ventricular drain, which we discussed already. Now, dealing with cerebral blood flow, we talked about one of the things you can do is ultimately you can paralyze a patient. If you paralyze a patient, you completely decrease significantly their body's metabolism and therefore decrease their body's temperature, and therefore you protect the brain. And then the last thing I will talk about in this slide is cerebral blood flow. And dealing with cerebral blood flow, just to remember, normal cerebral blood flow is 40 to 50 cc's per 100 grams per minute into the brain. And there is a linear relationship between CO2 and cerebral blood flow. So what do I mean with that? What I mean is in this picture on the left. So if you look at this picture, what you can see is I have arterial CO2 plotted on the bottom and cerebral blood flow on the y-axis. At a PaCO2 of 40, your cerebral blood flow is around 40 to 50 cc's per 100 grams per minute. At 20, it is about 20. At a PaCO2 of 20, it is about 20 cc's per 100 grams per minute. So as you can see, the correlation between them is very, very linear. So when do we say that it is dangerous? What blood flow is dangerous in terms of causing cerebral ischemia? So in general, when your cerebral blood flow reaches 25 cc's per 100 grams per minute, around there, that's when you begin to get worried of potential ischemia. So as a result, to give yourself some leeway of protection, you really don't want to hyperventilate anybody to anything below a PaCO2 of about 28 to 30. Because you already have ischemia from the intracranial hypertension, this is only going to make it worse. The other thing that you want to do in patients who have intracranial hypertension is you want to avoid hypoxia. Now, some neurosurgeons will sometimes say, let's keep the PaO2 around 80 to 100. Well, what we know about neurophysiology is that as the PaO2 is maintained between, say, 80, which is on the right side of this slide, to infinity, the CBF remains constant. But when the PaO2 reaches about 60, you get significant cerebral vasodilatation and the cerebral blood flow just skyrockets. This is actually similar to in your peripheral vasculature. When you have hypoxia in your peripheral vasculature, you get peripheral vasodilatation. The exception is the pulmonary vasculature. When you have hypoxia, you get something called hypoxic pulmonary vasoconstriction. The pulmonary vasculature and the systemic vasculature are the opposite in terms of how they respond to CO2 and oxygen. Okay. Okay. Moving on. Oh, before I keep going, just one other clinical pearl. In case you're in the ICU managing a traumatic brain injury patient and you're giving them mannitol and hypertonic saline, in general, you want to keep the serum sodium below 160 to again decrease the risk of causing renal injury from hypernatremia, and you want to keep the total body osmoles less than 320, and the osmolar gap, which mannitol can cause because it's an osmol that is not measured, below 10. Again, an osmolar gap below 10. In general, if you are using mannitol, you actually have to measure serum osmoles. If you're not using mannitol and only using hypertonic saline, you really don't have to measure serum osmoles. All you can have to measure, is your serum sodium, because you can calculate your serum osmoles by the formula of twice the sodium plus the BUN divided by 2.8 plus the glucose divided by 18. And unless there's some osmol that you're not measuring, and again, since you're not using mannitol in this scenario, you do not have to measure the serum osmoles. You can calculate it yourself. Now, I want to turn now to talk about seizure prophylaxis. So, after you have a traumatic brain injury, you are at increased risk of having a seizure. So post-traumatic brain injury seizures are classified as either early, such as within 7 days of injury, or late, after 7 days of injury. What we know is that giving seizure prophylaxis decreases the risk of early seizures, but not late seizures. Therefore, in this sort of literature, it is recommended that prophylaxis be given for about 7 days with either Keppra or Dilantin. People have moved towards Keppra as opposed to Dilantin, and the reason for that is with Dilantin, you have to measure levels and correct them for your albumin to make sure that they are therapeutic, while with Keppra, you don't have to do that. And the studies show that they're probably pretty much equivalent. What we found with seizure prophylaxis, though, is that even though there's a decreased risk of seizures in the first 7 days, there really is no outcome benefit by using seizure prophylaxis in the long term. But it makes physiologic sense that you really don't want somebody who just had an acute brain injury to have a seizure, because a seizure is basically haphazard activation of your brain cells, which therefore increases their metabolic rate. And we already talked about the fact that you want to minimize the cerebral metabolism. Now, which patients are at high risk for having early seizures? So in general, people with severe traumatic brain injury, remember a GCS of 8 or less, somebody who had an immediate seizure when they had their injury, patients with an epidural hematoma, a subdural hematoma, a cortical contusion, somebody who had loss of consciousness, somebody who had a depressed skull fracture. In other words, the skull actually goes beyond 1 centimeter from one part to the other, or somebody who had penetrating injury, for example, a gunshot wound. Okay? Now I'm going to turn your attention to traumatic brain injury complications. So there are cerebral complications. For example, you can have an infection in the brain, a meningitis, or an abscess from some sort of penetrating trauma. You can have a CSF leak, you can have seizures, hydrocephalus, a cranial nerve injury, a pneumocephalus, or air into the actual brain. An arterial venous fistula is some sort of knife or bullet for some reason passed by one of the cerebral sinuses and near an artery, you might have now a connection between them two, or a subdural hygroma. So you might say, what is a subdural hygroma? A hygroma is basically a subdural body of CSF. Then you can have non-cerebral complications. For example, neurogenic cardiomyopathy, also known as Takotsubo Cardiomyopathy, which I'm going to describe in the next slide. You can have infections such as pneumonia or line sepsis. Since I'm here with infection, I will note that what we do know is that in patients who have traumatic brain injury, at one point people thought that by giving steroids you might have an improvement because you have decreased inflammation, where it turns out that they had worse outcomes. And remember, steroids also increase your sugar. So in general, we just don't give steroids to patients with traumatic brain injury. Since we're also in the non-cerebral section, hypothermia has its own complications. We're talking about providing a little bit of hypothermia, if you can, in patients who have traumatic brain injury or just simply euthermia. So what we know about hypothermia, and still debated in the literature whether we should be using it for TBI as long as they're not coagulopathic, is that hypothermia causes shivering, which increases your total body's metabolism. It causes hypotension. It causes diuresis, which will complicate hypovolemia, which increases your risk of ischemia. The reason you get diuresis with cold temperatures is that your ADH does not function. You get hypokalemia, and you are at increased risk of having pneumonia, sepsis, and impaired clotting. You can develop also other complications of TBI are non-cardiogenic pulmonary edema, okay, also known as neurogenic pulmonary edema. There is risk of renal failure with the hypertonic saline and the mannitol, risk of stress ulcers, risk of coagulopathy. The brain has a lot of plasminogen, which when released increases your risk of activation of plasmin and breaking down of all these clotting factors, right? Breaking down of fibrinogen. Then you can develop nutritional deficiency because people sometimes don't get appropriate tube feeds because they're very sick. And then we also know as traumatic brain injury increases your risk of developing deep venous thrombosis in just a few days, which increases your risk of having a pulmonary embolism. So there's always a debate in the ICU as to when is the appropriate time to start chemical DVT prophylaxis with either heparin or enoxaparin, because there's a balance of trying to prevent a DVT-PE, but also the risk of developing a hemorrhage in the brain. In general, we started by 48 to 72 hours as long as the clinical exam is stable, or if you're using imaging, there's no signs of worsening on the CT head. So what exactly is Takotsubo's cardiomyopathy? Takotsubo's cardiomyopathy is a transient dysfunction of the midventricular heart and often the apex. It's also known as apical ballooning syndrome. It's associated with any kind of emotional or physical stress, specifically, for example, brain trauma. I had a patient who had a traumatic subarachnoid hemorrhage who was otherwise previously healthy, young person, and we noticed that she had some EKG changes. She specifically had some ST elevations, and obviously we were not going to cath her because, she had a subarachnoid hemorrhage and we weren't going to give her any heparin to do the cath, and I did a bedside transthoracic echo, and essentially the ventricles, the mid part of the ventricles was doing like this, and the apex was basically not moving, but the proximal part of the left ventricle was bounding away. So if you looked at her ultrasound, of her heart, starting from right where the aorta is coming out, it was bounding, and then as you went away towards the apex, it sort of just got weaker and weaker and weaker and weaker. This is classic Takotsubo's cardiomyopathy, which is sort of this reversible dysfunction of the heart in the setting of stress, often seen in postmenopausal women. It tends to get better in a few weeks, and often you get a repeat echocardiogram in about 4 weeks and you see an improvement. So I just wanted to show you a picture of what I mean by Takotsubo's cardiomyopathy. As you can see in this picture, you have the base of the heart right here. The base is the area that's right near the entrance to the aorta, which is seen here. Here's the mid wall, okay? Here are your papillary muscles, you can imagine, okay? And here is your apex. So what ends up happening is this part of the heart does not function, yet this part of the heart is extremely hyperdynamic, or just working well. So we often see it as apical ballooning syndrome, because as this part of the heart contracts and this doesn't, this actually, the apex balloons out every time instead of contracting. So you see the base contract and the apex sort of comes out. Okay, well, this concludes part 2 of the TBI lecture. I hope that you find it to be very useful for your USMLE, and to me, most importantly, that after having seen these 2 parts of this lecture, you will feel much more comfortable with traumatic brain injury, its management, and its complications. Okay, this is, thank you very much.